Welcome to the Deep Dive. Today we're plunging into, well, the fascinating, pretty intricate world of medications.
Yeah, they're incredibly powerful tools, often life-saving, really.
Exactly. But their complexity, how they work inside us, and, their potential pitfalls, it's just endlessly captivating. So we're going to explore a kind of blueprint of critical medications, looking across various health conditions.
Right. And the goal isn't just like memorizing names.
No, not at all. It's about understanding why these drugs work,
Yeah.
what surprising effects they might have, and the crucial considerations for using them safely and effectively.
We want to give you that shortcut, that deeper understanding, so you feel really well informed.
Exactly. Our insights today come from a pretty detailed blueprint of pharmaceutical knowledge, just packed with essential details.
Yeah, and this deep dive is all about unlocking those complexities for you so you can grasp how these vital meds operate, what makes them so impactful, and, the critical things to keep in mind.
Helping you feel truly confident in your understanding. Okay, let's start by unlocking the mind a bit. Focusing on behavioral health and neurological medications.
Good place to start.
We're kicking off with Disulfiram, which many people know as antabuse.
Right. This one's used for alcohol use disorder.
And its mechanism is quite clever, isn't it? It interferes with how your body processes alcohol.
It does. Specifically, it inhibits an enzyme, aldehyde dehydrogenase.
And that inhibition, what does that actually do?
Well, that's the key. When someone on disulfiram drinks alcohol, a toxic compound called acetaldehyde builds up really fast. And that buildup causes this intensely unpleasant reaction. We're talking flushing, nausea, vomiting, heart palpitations. It's a strong aversion therapy.
Basically turns alcohol into something you physically reject.
Pretty much, yeah. It's powerful.
But it comes with some incredibly important safety points.
Yeah.
You absolutely cannot give it if the patient isn't sober, right?
Correct. They need to be alcohol-free for at least 12 hours, minimum.
And here's something that often catches people out. Those reactions can happen up to 2 weeks after stopping the drug.
That's a huge window. People really need to know that.
And it's not just about avoiding beer or wine. It's all forms of alcohol.
Right, even the surprising ones. Cough syrup, some aftershaves, mouthwash.
Hand sanitizer.
Yeah.
Even cooking extracts like vanilla or vinegar. Just triggering that with dessert.
Yeah, it requires real vigilance. And you also have to avoid giving it with metronidazole or paraldehyde.
Why is that?
They can cause similar, quite severe reactions. Plus, you need to monitor liver function tests, and it can get into breast milk, so lots to consider.
Definitely. Okay, next up, a drug that's literally life or death in emergencies. Naloxone or Narcan?
Yes, Narcan, for opioid overdose, specifically reversing that dangerous respiratory depression.
How does it work so quickly?
It's an opioid antagonist. Think of it like a key that fits the opioid receptor lock but doesn't turn it on. It just blocks it.
So it physically kicks the opioid off the receptor.
Essentially, yes. It competes for that space and wins, reversing the opioid's effects, especially on breathing.
And administration is flexible too, right?
I am subcutaneous, even intranasally, which is vital for quick use outside hospitals.
Dosing.
Usually start with 0.1 to 0.2 milligrams, repeat every couple of minutes until they respond. But here's a really crucial point.
Okay.
Naloxone has a short half-life, much shorter than many opioids.
Meaning it can wear off while the opioid is still active?
Exactly. So the person might seem fine, but then slip back into overdose. Repeat doses, maybe even a continuous infusion might be necessary. It buys time, but doesn't eliminate the opioid.
Wow, okay, so vigilance is key even after they wake up.
Absolutely. And it can also trigger acute opioid withdrawal. Agitation, pain, high blood pressure, vomiting. It's rough, but necessary.
A difficult trade-off indeed. Okay, let's shift to Bupropion, known as Wellbutrin, used for smoking cessation and depression.
Right. It works by increasing dopamine and norepinephrine in the brain. Sort of mimics nicotine's effects, which helps with cravings.
But it comes with a significant warning, doesn't it?
It does. A black box warning. Risk of hostility, agitation, depression, even suicidal thoughts, especially when starting, needs careful monitoring.
Anything else?
It can lower the seizure threshold, so caution in people with seizure risk. And it reduces appetite, so generally not for those with eating disorders.
And timing matters for sleep.
Yeah. Take it in the morning usually to avoid insomnia. And like many antidepressants, tell patients it takes several weeks to really kick in.
Good points. Now, let's broaden out to antipsychotics. a whole class for treating psychosis symptoms like in schizophrenia. We usually divide them into FGAs and SGAs, right? First and second generation.
Correct. FGAs are the typicals, SGAs the atypicals. The main difference often lies in what symptoms they target best and their side effect profiles.
So tell me about an FGA like fluphenazine.
Okay, fluphenazine primarily blocks dopamine. Very effective for positive symptoms, hallucinations, delusions.
But the downside?
Because it hits dopamine pathways involved in movement, there's a higher risk of extrapyramidal symptoms, EPS. We'll talk more about those. Other side effects too, like dry mouth, blurred vision, weight gain, sexual dysfunction.
And avoid alcohol and CNS depressants.
Definitely. And even things like kava.
Okay, how about the SGAs like risperidone? How are they different?
Risperidone blocks both dopamine and serotonin. This dual action often helps with negative symptoms too, things like apathy or withdrawal, which FGAs don't usually address as well.
But they have their own issues.
They do. With risperidone, you still monitor for EPS, but also watch for metabolic things. Weight gain, high blood sugar, risk of NMS and TD2, which we'll define. And it can increase prolactin, potentially causing things like gynecomastia.
So it's a trade-off. Newer drugs aim to reduce movement issues, but brought in metabolic ones.
That's often the case, yeah. It's always balancing benefits and risks for the individual patient.
The sources also mentioned clozapine, another SGA, but kind of a last resort.
Exactly. Because of a really dangerous side effect?
Yep.
A granulocytosis.
Which?
A severe drop in white blood cells. Leaves the body incredibly vulnerable to infections. Requires super strict blood monitoring.
Got it. Okay, you mentioned EPS, NMS, TD. Can we break those down? They sound serious.
They are. Very important to recognize. Extrapyramidal symptoms, EPS, are a group of movement-related side effects.
Like?
Dystonia, involuntary muscle contractions, often painful spasms in the neck or face. Then akathisia. This awful inner restlessness, feeling like you absolutely cannot sit still, and pseudo-Parkinsonism, symptoms that mimic Parkinson's tremor, stiffness, shuffling walk, drooling.
Okay. What about NMS?
Neuroleptic malignant syndrome. Rare but life-threatening. The body just goes haywire, altered mental state, extremely high fever, rigid muscles, unstable blood pressure, heart rate, sweating. A true medical emergency.
Wow. And TD.
Tardive dyskinesia. This usually happens later, after long-term use, and can be irreversible. It's involuntary, repetitive movements, lip smacking, tongue rolling, often face and mouth, but can affect limbs too, something we always try hard to prevent.
Okay, that's a lot to watch for. Let's pivot slightly. Emergency reversals again. Flumazenil or romazicon?
Right, this one's for reversing benzodiazepine sedation or overdose. Benzos like Valium or Xanax.
And it works by blocking them.
Yeah, it's a benzodiazepine antagonist. It basically jumps into the benzo receptor spot on the GABA receptor and blocks the benzo from acting.
So what's key when using it?
Monitor consciousness, breathing, airway very closely before and after. Watch for seizures. Give it IV push, but slowly, over about 30 seconds.
Any contraindications?
Big one. Avoid in patients with a seizure history or those who use benzos chronically.
Why is that?
Suddenly reversing the benzo can trigger severe withdrawal seizures. Very dangerous. Other side effects can be seizures, nausea, dizziness, agitation.
Makes sense.
Yep.
Get another major class, antidepressants. MAOIs, SSRIs, TCAs. Let's start with the monoamine oxidase inhibitors, MAOIs.
Okay. MAOIs work by inhibiting the enzymes that break down key neurotransmitters, norepinephrine, dopamine, epinephrine, serotonin, so levels of these go up.
But they come with a major warning, right? Hypertensive crisis.
That's the critical one, a dangerous spike in blood pressure. And it means huge dietary and drug interactions.
The tyramine thing.
Exactly. Patients absolutely must avoid foods high in tyramine. Think aged cheeses, cured meats, pickled stuff, certain beers and wines, even coffee. Basically, your typical charcuterie board is out.
Wow, that's restrictive. Any drug interactions?
Oh, yeah. Avoid CNS stimulants, vasoconstrictors, many cold meds, other antidepressants, and even herbal things like ginseng, ephedra, St. John's wort. It's a long list.
Definitely needs careful patient education. Okay, moving to the SSRIs. Sertraline, Zoloft, very common.
Very. Used for depression, OCD, PTSD, panic disorder. The mechanism is simpler. It selectively blocks serotonin reuptake. More serotonin available.
What should patients know? Side effects.
Initial side effects like nausea or maybe feeling a bit jittery often fade in a week or two, but not always. Take it in the morning if it causes insomnia.
And interactions. You mentioned St. John's wort before.
Yes, absolutely avoid St. John's wort. Also, avoid grapefruit juice. Both increase the risk of serotonin syndrome,
Let's
a potentially dangerous condition. Too much serotonin activity causes confusion, agitation, rapid heart rate, muscle rigidity, can be serious. Also, watch for increased suicidal ideation, especially early on in younger people.
Right. Okay, last antidepressant type here. TCAs, tricyclics, like amitriptyline, Elavil.
Yep, used for major depression. TCAs increase both norepinephrine and serotonin, and also block acetylcholine.
Key concern with these.
Cardiotoxicity is a big one. Risk of heart rhythm problems, dysrhythmias. That's why patients usually need periodic EKGs.
And administration.
Usually take it at night because it's sedating. Always taper off, don't stop suddenly, and it's generally a no-go right after a heart attack or with certain types of glaucoma.
Got it. Finally, for this section, lithium, the mood stabilizer.
Primarily for bipolar disorder, preventing and treating mania. The mechanism isn't fully understood, but it likely involves enhancing norepinephrine and serotonin reuptake and affecting sodium-potassium electrical flow in neurons.
The really critical thing with lithium is
The narrow therapeutic index, tiny window, 0.5 to 1.2 MEQL. Very easy to slip from therapeutic to toxic.
so monitoring is key. What are the side effects or signs of trouble?
Can cause fluid balance issues, lots of peeing, thirst, diarrhea, vomiting, edema. Mild hand tremor is common. Can also cause hypothyroidism and heart rhythm issues. Needs weekly blood tests at first, then monthly, to keep those levels just right.
Intense monitoring needed there. Okay, let's shift gears. Let's talk about infections and immune challenges, starting with tuberculosis, TB.
Right, caused by Mycobacterium tuberculosis. Spreads person to person through the air, via droplets, classic symptoms, cough, sometimes bloody sputum, fever, night sweats, weight loss.
And treatment is complex, isn't it?
Very. Single drugs just don't work because of resistance. You need multi-drug therapy, sometimes up to 5 drugs, and for a long time, up to 9 months.
9 months. Adherence must be a huge challenge.
It's absolutely crucial. If people stop treatment early, even if they feel better, they risk developing drug-resistant TB, which is much, much harder to treat.
There's an acronym for the main drugs.
Yeah, RIP is common for the first-line meds. Rifampin, isoniazid, INH, pyrazinamide, and ethambutol.
Let's focus on isoniazid, INH. Any key points?
Take it on an empty stomach, usually an hour before or 2 hours after food. And here's an interesting thing. Give kiridoxin, vitamin B6, alongside it.
Why B6?
To prevent peripheral neuropathy. Nerve damage, often painful tingling or numbness in hands and feet. It's a common side effect of INH, and B6 helps prevent it.
Smart. Anything else?
Definitely avoid alcohol, big risk of liver damage, hepatotoxicity, and regular eye exams are needed because of a risk of vision problems, something shared with ethambutol too.
Okay. Now a quick run through some other antimicrobials. Acyclovir.
Antiviral, mostly for herpes viruses, shingles, cold sores, genital herpes. Stops the virus making DNA. Can be used preventatively too. Be cautious with kidney problems or seizure disorders, and it can pass into breast milk.
How about Amphotericin B? Sounds ominous.
It gets called amphoterrible for a reason. Significant side effects. It's a powerful antifungal, but reserved for really severe systemic fungal infections.
So how do you manage the side effects?
Often need pretreatment, giving things like acetaminophen, diphenhydramine, maybe hydrocortisone 30-60 minutes before the infusion helps lessen the reactions, and close monitoring of kidneys and liver is essential.
Okay. A more common antifungal. Fluconazole.
Yep. An azole antifungal, used widely, comes in oral, IV, vaginal, topical forms. Big caution here again, no alcohol, risk of liver toxicity.
Chloroquine. I think of malaria, but you mentioned autoimmune too.
Exactly. Used for malaria, yes, but also for things like lupus and rheumatoid arthritis. The key thing, especially for long-term autoimmune use, is the risk of eye damage retinopathy.
Yeah.
Needs baseline and regular eye exams.
And metronidazole.
Yeah.
Used for it.
Anaerobic bacteria, C. diff, and protozoal infections like trichomoniasis or giardiasis. The absolute key point, do not mix with alcohol. Causes that severe disulfiram-like reaction we talked about. Awful nausea, vomiting, flushing. Also best avoided in the first trimester of pregnancy if possible.
Good heads up. Okay, let's talk about antiretroviral therapy, RAT, for HIV. Truly transformative.
Absolutely. Changed HIV from almost certain death sentence to a manageable chronic condition for many.
What are the main goals of ART?
Reduce illness and death, obviously. Prolong life. Restore immune function, get that CD4 T cell count up. Suppress the virus, the viral load. and prevent transmission to others.
Viral suppression is key, right? Getting it undetectable.
That's the goal. Below detection, usually 20-40 copies ml within about 16-24 weeks. Compare that to a normal CD4 count of 500-1500. Below 200 CD4 cells is an AIDS diagnosis.
And adherence, I hear that's paramount.
Non-negotiable, really. Missing doses lets the virus replicate and worse, develop resistance to the drugs. Makes treatment much harder, sometimes impossible.
What about ART during pregnancy?
Recommended for all pregnant individuals with HIV. It dramatically cuts the mother-to-child transmission risk from around 25% down to 1 or 2%. Amazing.
Incredible. Any specific measures during labor?
If the viral load is still high, over 400 copies, IV zidovudine might be given during labor, but breastfeeding is generally not recommended, still a small risk.
Okay. Shifting to transplant drugs and immunosuppression, the big challenge is rejection. Right?
Exactly. The patient's immune system sees the new organ as foreign and attacks it. So we use immunosuppressants to dampen that immune response.
It's a balancing act.
A very delicate one. Too much suppression, and the patient is wide open to severe infections. Too little, and the organ gets rejected.
Let's talk about specific drugs. Cyclosporine.
A key one. Calcineurin inhibitor. Prevents rejection.
Right.
Side effects include kidney toxicity, high blood pressure, gingival hyperplasia, that's gum overgrowth, and hirsutism, excess hair growth.
And there's a crucial food interaction.
Yes. Absolutely no grapefruit or grapefruit juice. It dramatically increases cyclosporine levels, risking toxicity. Really important point.
Good to know. How about sirolimus?
Another one, an mTOR inhibitor. Also prevents rejection, but carries a risk of lymphoma and other cancers. And like all immunosuppressants, increases infection risk.
So general care for transplant patients focuses heavily on infection prevention.
Hugely. Meticulous patient education, hand hygiene, safe food prep, being careful with gardening because of soil fungi, good skin, and mouth care. Knowing the signs of infection and when to call for help immediately.
And vaccines.
Critically important. No live vaccines for these patients. Their suppressed immune system can't handle them.
Do they take preventative meds too?
Often, yes. Prophylactic drugs to prevent common opportunistic infections, like Bactrim for PCP pneumonia, nystatin for thrush, maybe Acyclovir for CMV.
Makes sense. Okay, final segment, cancer treatment and GI health, starting with chemotherapy. These are high alert meds, right?
Extremely high alert. High potential for harm if errors occur. Safety is paramount for everyone involved.
We need PPE.
Absolutely. Specialized chemo gloves, impermeable gowns, masks with eye shields, extra precautions for staff who are pregnant, breastfeeding, or trying to conceive. Chemo is usually given in cycles, often combination therapy, to hit the cancer harder and from different angles.
And it affects healthy cells too.
That's the challenge. It targets rapidly dividing cells. Cancer cells divide fast, but so do cells in our hair follicles, GI tract lining, skin, and bone marrow.
Which explains the common side effects.
Exactly, though many are temporary. A key term is nadir.
Nadir.
It's the point after chemo when blood cell counts are at their lowest, especially white blood cells. That's the time of greatest risk for infection due to myelosuppression, bone marrow suppression.
So common side effects are bone marrow suppression leading to low white cells, low platelets, low red cells.
Right, leukopenia, thrombocytopenia, anemia, plus GI issues. Nausea, vomiting, diarrhea, painful mouth sores called stomatitis, hair loss, alopecia, skin reactions, reproductive issues, impaired wound healing.
And what about extravasation? That sounds bad.
It is. Especially with vesicant drugs. These are chemo drugs that cause severe tissue damage, blistering, necrosis if they leak out of the vein. Prevention is key, using good IV sites, maybe central lines.
But if it happens...
Stop the infusion immediately. Try to aspirate any drug left in the line. Give an antidote if one exists for that drug. Then remove the cannula, apply a cold or warm compress depending on the drug, and elevate the limb. Quick action is vital.
Okay. Specific chemos. Cyclophosphamide, Cytoxan,
an alkylating agent. Big risk here is hemorrhagic cystitis, bleeding bladder, so push fluids 2-3 liters a day. Sometimes give Mesna, a bladder protectant, and it's teratogenic, causes birth defects. Use reliable contraception.
Doxorubicin, Adriamycin, the red devil.
Sometimes called that, yeah. And anthracycline, key issue. Cardiotoxicity,
right.
Heart damage. Need baseline heart function tests, monitor closely. There's a lifetime cumulative dose limit. Go over it, and irreversible heart failure risk skyrockets. Causes Reed-Dorn tear is harmless, but good to warn patients. And it's a strong vesicant, so central line preferred if possible.
Okay, now moving to anti-neoplastics or targeted therapies, how are they different from traditional chemo?
More specific, They target particular molecules or pathways involved in cancer growth, often found more in cancer cells than normal cells. More deliberate, often cytostatic slowing growth rather than cytotoxic killing cells broadly, hopefully fewer side effects on healthy tissues.
Like bevacizumab of that.
Right, that's an angiogenesis inhibitor. Stops tumors from forming new blood vessels, essentially starving them.
Key risks.
Black box warning for hemorrhage bleeding, and shouldn't be used within 28 days of major surgery because of that risk.
And cetuximab.
That's an anti-EGFR monoclonal antibody. Also has a black box warning, this one for severe, potentially fatal infusion reactions, anaphylaxis, airway issues, low blood pressure.
So safety precautions.
Absolutely critical. Resuscitation equipment must be right there at the bedside during administration.
Got it. How about biologic response modifiers?
Yeah.
BRMs.
Immunotherapy. These work differently again. They stimulate the body's own defenses to fight disease, or they help manage side effects of cancer treatment, particularly by boosting blood cell production that chemo knocked down.
Example, epoetin alpha, Procrit.
Stimulates red blood cell production. Monitor hemoglobin target usually under 11 GDL to avoid cardiovascular problems like clots, stroke, MI, also risk of hypertension.
And filgrastim, Neupogen.
Boosts neutrophil production, those key white blood cells for fighting infection. Monitor WBC count, hold if it gets too high. Common side effect is bone pain. Keep an eye out for splenomegaly, enlarged spleen, rare risk of rupture. So report left upper quadrant or shoulder tip pain.
Okay, final topic area, gastrointestinal drugs.
Yeah.
Emetics versus adsorbents.
Emetics make you vomit use is cautioned now, especially at home. Adsorbents like bismuth, subsalicylate, Pepto-Bismol, absorb toxins, help with diarrhea. The interesting, harmless thing about Pepto is it can turn your stool and tongue black.
Good to know. Psyllium, Metamucil.
Bulk-forming laxative. Key administration point. Mix it in a full 8-ounce glass of water or juice right before drinking, and then drink another full 8-ounce glass immediately after.
Well, that's so much fluid.
If you don't take enough fluid, it can swell up and cause a blockage in the esophagus or bowel. Really important.
Nopramide Imodium for diarrhea.
Opioid antidiarrheal. Slows down gut motility, low abuse risk. The key thing,
Yep.
Don't use it if the diarrhea is caused by a bacterial infection. You don't want to trap the bugs in there.
Makes sense. Bisecadil, Docalax.
Stimulant laxative. Works faster as a suppository, 15 to 60 months, than oral, 6-12 hours. Take oral tabs on an empty stomach for faster effect. Avoid antacids and milk within an hour. They can mess with the coating.
Okay, nearly there. Anti-ulcer drugs. Bamotidine, Pepsid.
An H2 blocker. Reduces stomach acid by blocking H2 receptors. Give just before meals. Might need a lower dose in elderly due to confusion risk. Smoking makes it less effective. Can cause reversible impotence or gynecomastia sometimes.
And the PPIs, omeprazole, Prilosec, esomeprazole, Nexium.
Okay, proton pump inhibitors. Very effective. They block the actual acid pump enzyme, H plus K plus ATPase. Really shut down acid production.
Pervisceration.
Take on an empty stomach. 30-60 minutes before the first meal. And here's the thing. They're really meant for short-term use. 4-8 weeks usually.
Long-term use has risks.
It can. Linked to vitamin B12 deficiency, increased risk of osteoporosis and fractures, and even a higher risk of C. diff infection. So use the lowest effective dose for the shortest time needed.
Good advice. Finally, H. pylori treatment. Why is this important?
H. pylori bacteria is a major cause of peptic ulcers. Getting rid of it is crucial to prevent ulcers from coming back.
And treatment involves?
Combination therapy.
Right.
Usually 2 or 3 antibiotics like amoxicillin, clarithromycin, metronidazole, tetracycline plus a PPI or an H2 blocker.
Specific regimens.
Triple therapy is common. PPI plus amoxicillin plus clarithromycin.
Or?
Quadruple therapy. PPI plus bismuth plus metronidazole plus tetracycline.
Key points for patients.
Take the entire course. Avoid alcohol if metronidazole is involved. Stool might change color from the bismuth.
And non-drug measures are important too, right?
Absolutely. For ulcers, avoid tobacco, alcohol, spicy, greasy foods. Take NSAIDs or steroids with food. Sit up after eating. Don't eat right before bed. Wear loose clothes. Lifestyle matters.
Wow. We've covered a huge amount of ground today. An incredible array of medications. Mental health, infections, cancer, transplants, GI.
It really highlights the complexity, doesn't it? Not just the number of drugs, but how intricately they interact with our bodies, with other things we ingest. The precision needed.
It's a delicate dance, for sure. And understanding these fundamentals, it's not just for doctors or nurses. It empowers everyone to be more informed about their own health.
Absolutely. Being equipped to understand the landscape of modern medicine is vital.
So the final thought to leave you with, what does this all mean for you?
Yeah, consider how something seemingly simple, maybe a food choice like grapefruit or an herbal supplement you pick up, how that could profoundly change how a life-altering medication works or even its safety.
It really makes you think about that delicate balance inside us and, well, the power of knowing what you're putting into your body, doesn't it?
It certainly does. Knowledge is powerful.